We're going to call the insurance committee meeting to order. With that, I'm going to turn it over to Michael.
Oh, okay, thank you. All right, does everyone have a copy of the printouts that we supplied, and Kelly's going to show them up on the screen also. All right, so thank you all very much for being here. As you certainly know, this is our annual meeting for the Health Insurance Committee to make its recommendations on the premium equivalents for the upcoming year. And as you know, we don't have, we're an ASO plan, so we calculate what's called a premium equivalent. And we usually try to sit back and look at what our previous expenses were in order to establish that. So if you were to look at your first page of comparison, well, first of all, I'd like to just say and thank you to Rob Lamoureux from UPSCU for joining us. All of our unions were invited, but unfortunately, representatives from Council 82 were not able to be here in person. So just to let you know. So looking at the comparison of premium equivalent components, what that is Lori Halstead did an amazing breakdown of looking at our years from 2020 through our current 2023. But please know that our October, November, and December numbers in there are based on estimates from our previous 9 months of claims. But I think it's very easy to see the increased costs of certain aspects of our healthcare. You know, certainly 10% increase in our health insurance claims is one piece of the component of our premium equivalents, but you know, certainly our county controller and our county treasurer can speak to our increasing health costs that come through. We do pay these claims on a weekly basis by wire. This is real money. These are claims that actually come in, and you know, we have to pay them as they go. And understanding that in addition to our stop loss increased costs, you know, we used to traditionally have a stop loss laser of $250,000, which has now been raised to $300,000. So the qualification for the stop loss certainly increased for us as well. So just to get an idea, that's really what this is, just for reference, so you can see the increase in costs, as I don't think that anyone here is surprised. Would anyone here have any questions for either myself or for Lori in regards to the information on the comparison sheet?
Michael, what goes into the admin cost? What is that?
So the admin cost is what we pay to CDPHP to actually oversee the plan.
Okay.
So it's a flat fee that we pay per person in the plan each month. I'm sorry, excuse me.
Thank you.
Thank you. Anyone else? Okay, so let's get into the meat and potatoes. So if you look on the second page, Lori had calculated all in one place for us the historical rate changes, just to give you an idea of what we have been able to do over the last 9 years. We did start in 2015, where certainly we didn't have any type of perspective or starting points. We started with our 2014 premiums, and then how we were able to calculate and either increase or 1 year even be able to decrease based on what our premiums were. And unfortunately, you know, every year, as you saw in our other document, the claims just continue to keep going up and up. Health insurance is one thing that we can look at trends, but we really don't know. All you need, especially as an ASO, is one particular case to be a very, very high cost notification, and it can be detrimental to the expenses that go within these programs. And not to put Lori in the hot seat, but Lori certainly has some information that, you know, without us violating HIPAA, would be able to answer some questions about some of that stuff as well. Okay, all right. So looking at what our 2023 premiums that we had established at the same meeting last year, and then understanding what that means underneath that, the different rates apply to the different parts prior to June 13th of 2018, when we had negotiated with UPSCU for management and them to have a flat 20% for every new person that's coming in. So there's your census. There is our breakdown between our health insurance as well as actual health claims, excuse me, versus our prescription, which are both through CDPHP, but just to give you an idea of the two of them. Contributions is a calculation based on it's the actual number, excuse me, that comes in through the percentages that the county pays as well as the employee pays. Okay, so as you can certainly see in 2023, based on the contributions that the county is committed to pay and the employee, is committed to pay, we're at just under 11 million with expenditures that anticipated at 13.9. It's my understanding we just got another high cost notification in the month of October, which is not live on this, so that number already has gone up. All right, so looking at this, we can see that we are already at a shortfall of just under $3 million compared to what we are collecting from our employees and from what the employer share is, but please understand that this number does not reflect the rebates from the prescriptions. Okay. So does anyone have any questions about this? Okay. So I was asked to just kind of run some case scenarios, okay? So first and foremost, I do just want to educate you, please, where you see in the column where it says 127%, 100, please know that that is not a 127% increase. It's a 27.3% increase. It's just, for some reason, I could not remember how to get that cell to work to show that. And unfortunately, our very smart Jim Bragg, our controller, was in a meeting, so I wasn't able to ask him how to do that. So I scared poor Elena by seeing 127. She's like, "Are you kidding me?" So I apologize if I caused anybody.
I know how you get the inverse.
All right, perfect. So we'll talk. We'll talk on that. All right, perfect. Okay, so please know that the first one on the top is certainly not one that we're asking anyone to consider or to look at. What's that? Yeah, but know that we just wanted to give what a break-even scenario for current cost is. So looking at the fact that our premium equivalents would have had to have been raised by 27.3% for all of our employees and county contribution in order for the estimated contributions to be $2,300 less than what the county would be anticipating to pay. And certainly respecting and understanding that I would never feel comfortable looking at a 27% increase. And I don't think that the committee's looking to make that type of recommendation or have that conversation. So, but just to give you an idea of what actually would be a break even in this environment, okay? So, you know, from our brokers and certainly from experience from Lori's exposure dealing with CDPHP, we're looking at it's a 12.4 is the average now for the increase in the ASOs. So that is where we pulled a 12% increase from conversations with CDPHP. They said traditionally for 2024, there was a 12% increase for ASOs. So what is broken down here is by using our 2023 premiums, it gives you an idea of what exactly that would do to our premiums, and then gives you a breakdown of what the health would be, what the RX would be, what the total per check would be, but more importantly, what the difference per check would be for each employee, okay? Because I think that's really the focus that we want to look at as well. And then underneath that, we also did a comparison of a 15% just to get some sort of comparison there. So on a note, Lori also did some extensive research in reference to, you know, certainly being a municipality and being in the county. We do share a lot of employees with the state of New York, and that's either from people who are looking at potentially state jobs or come from state jobs, and then they look at what the New York State Health Insurance Program NISHIP has to offer. In addition to the fact that we do have a lot of staff who have spouses who are working for New York State. So they're constantly comparing NISHIP to what the county has to offer. And we're still very proud to hear when the words Cadillac coverage come up in reference to Columbia County's health insurance coverage. We hear it from individuals with New York State. In fact, we heard it this year from a very, very high cost claimant who had dealt with Westchester Medical, who, when her social worker said to her, "Yeah, don't ever leave Columbia County. You have one of the best insurances I've ever seen." So, and she said she would actually testify to that. So anyways, just to give you an idea, when we pulled up the 2023 rates, you know, certainly NISHIP is known for its Empire plan for New York State. Family coverage for the Empire plan for NISHIP, they are this year. Now that's not including the 2024 rates. They have $287.98 a paycheck taken out. their CDPHP plan, which would be comparable to our CDPHP plan, $257.87 comes out of paycheck. And their MVP plan is $249.27. That's each paycheck. And again, I remind you that that's, without 2024 increases. And pulling out through their state website for their cost of coverage and shares of premiums, we see here for dependent coverage, because New York State does not offer employee plus one. It offers individual and family, individual and family. So every employee that we have that is them plus a spouse or them plus a child or them plus someone qualified would have to be pushed to a full family plan if this was their situation. The New York State share is 69%. The employee bears 31% of the family health insurance coverages. Okay, so I just wanted to add that, certainly not as a negative towards anyone. It's just to give an idea of a lot of times when we talk about things, New York State gets thrown in our face comparably with a lot of things. So Lori did a lot of extensive research on, well, what exactly happens? Like, what happens to an employee if they go to New York State, and what would they pay, or what would their benefits be? And actually their co-pays were,
Their copays were very comparable to ours, but their copays for prescription were more. They were $530 and $670 for 30-day prescription.
Right.
We're $520.40.
yeah. So there was a couple of different things that stuck out there that were even higher cost to the employee on a regular basis. So Chairman, I don't know if you want to turn it over to, but certainly if anyone has any questions on this, please direct them to either myself or Lori, and we'll be more than happy to kind of let you know what we did. And if not, then I guess we'll just turn it back over to you, sir.
Well, it's clear we're gonna have to raise premiums. And just, you can't keep operating in the red, so.
How much do we have in a reserve fund now?
Yeah, I was just gonna bring that up.
Oh, I'm sorry.
In addition to this, I mean, our standard has always been to have approximately 10% of the premiums in reserve. So essentially, we should have about 1.4 million in reserve. As I sit here, we have $200. That's $200, okay? So we have depleted our reserve on top of the $13.9 million cost of the insurance. And as of this date, we have essentially funded this program with, and like I said, as of this date, we've funded this program to the tune of $2 million over projections. So, again, I think it's important that everybody here understands that we tend to look at this from a historical perspective of where we were, but we are so far behind that it's important that we try to make up some ground moving forward here. Because the 13.9, obviously, when we do our regular budget projections for the departments, we're looking at the year ahead and trying to project ahead. So on top of the 13.9, if we take into consideration a nominal 6% increase in healthcare costs, it's going to push us up to about 14.7. So essentially, as a county, we're already going to be behind, even with a 12% increase. So just to give you some perspective.
If our insurance plan, and I agree that it is as strong as it is, have we seen a significant number of subscribers or enrollment?
As far as
It's in terms of the number of people. If there are two, let's say there are two adults in the household, and they've gone from the other adult's plan to our plan because it's a better plan.
do you want to comment on that, Lori?
Not generally. We did have a couple flip over from the state 2 years ago, I think, when they really bumped up their percentages. So that was maybe 3 or 4.
So not significant,
No.
not a factor. Okay.
We've had a lot of individuals coming on more now than family. It's like we're hiring more individual people that are not married, no kids, that type of stuff lately.
Okay.
The past year especially.
And we don't insure domestic partners. We only insure,
We
families.
do not.
Okay.
We do not have a domestic partner rider.
And is there additional charge for buyouts? Do we have an additional, number that's, I know it's not directly related to the
That's
fee.
negotiated.
So I'm just wondering what the total exposure is.
I can answer at least with regard to the buyout. It had been relatively low before, and we just, increased it with UPSU, which is our largest bargaining, which then impacts NBUs. And it's been accepted by two of the other three units, which is 2,000 and 3,000, and I can have, Laura can explain it to you more. In fact, it's funny you asked that, Supervisor.
I just wrote it down.
I just wrote, what about buyout? You know, should we be engaging that as an option?
Yeah.
It must be. I know, Laura, you can maybe explain what that means, the 2,000 buyout.
Well, for individual, if you have if you would have taken an individual plan, but a lot of kids are on their parents,
Mhm.
so they don't take it, so they get the 2,000. Families who are on their spouses that don't work for the county would get the 3,000. I think Sheriff's Department's still lower. as
They
of right
are,
now.
but that is
Negotiating.
that has been offered. I can at least, not to disclose negotiations, but that is obviously a favorable increase because that's more money for people with the hope that they would transition. But I just said to Michael, perhaps that's something we need to further look at to entice when claims are going up. Do we know if the state does a buyout? And if so, what is the state's buyout?
They do a buyout.
They
but I'm
do?
not sure what it is now.
No,
I've been going a while.
I don't know if I know anything on the buyout.
The break even scenario seems to be very close to what towns are paying.
The state is 1,000 for individual, 3,000 for family.
Thank you.
You're
Okay, any other questions? Any?
Can I just ask a quick follow-up about the
Sure.
reserves? Obviously, that's unusual. Is there any general, and I'm asking, so I'm sure I'm gonna get this question from my members. Is there any particular reason why they've fallen so precipitously?
Obviously, because of the healthcare costs, especially during COVID. Okay, we had an additional healthcare cost for some of the COVID people, and we had to use funds out of the reserve.
Thank you.
And in these isolated cases, right?
Well, the isolated cases, the high-cost cases that we're being hit with this year are actually coming out of the general fund because there is no reserve.
And I also feel too, our inpatient, procedures have been on the rise. And we've looked at a lot of that. You know, you figured during COVID, a lot of individuals did not go to have a colonoscopy, let's say, as an example. You know, a standard procedure that even though they should be having it, a lot of hospitals and doctors weren't doing those procedures unless they were emergency or had to be referred in. So we had a number of individuals certainly this year, kind of just getting caught up, you know, on traditional type preventive outpatient, procedures.
We saw that in the town level too.
I'm sure, yeah. A lot of dermatology going through like that as well, things that unless God forbid it was an emergency, they were able to put off. But then as soon as a lot of that fog cleared, then 2023, they run in. You don't have to raise your hand.
Well, I feel like I should. If you look at the first page, you'll see that the real shocker, I think, here is the prescription drug, which has gone up substantially from what it was a few years ago. It's an increase of more than 50% from 2020, and that's specifically because of high-cost drugs. They're new drugs that are targeted to very specific disease states that were not available before, and they all cost a minimum of $4,000.
Minimum, yeah.
So you're talking about one of these drugs, and it's a $50,000 cost, and we have dozens of them now. So,
Anything advertised on TV is
Yeah.
minimum of 4,000 or 5,000,
yeah,
Oh,
it's,
yeah, right.
minimum. And then people go to the doctor and say, I want this.
Yeah.
You know, TV said it would cure them.
and it's true, it does cure them, it makes a big difference.
Yeah.
So, I know that some of the people within our discussion actually take specialty drugs, and they're lifesavers, but they're very, very expensive.
And a lot of these medications is what allows our employees to be able to continue to work. rather than them having to, retire early or to have to leave. A lot of these
On
medications
disability.
allow them to continue to be able to function with their essential day-to-day functions, so,
Makes a big difference.
as well as their dependents.
So it's a love-hate relationship with the pharmaceutical industry.
Okay, so before we move on, any other questions? I guess what we have to discuss is what our preferences in terms of the plan.
The 20% increase doesn't allow us to make any contribution to the reserve fund, right? Which starts to recover some of the other additional costs.
Yeah, hopefully, you know.
And that's based on guesstimating claims for next year. We don't know if they'll be the same. We don't know if they'll be less. They could be more next year too. Unfortunately, we don't know.
You don't have a magic.
I wish I did.
I
I wish I
Less.
did.
Yeah, she's pretty much.
So how would we, fund the reserve? Is that through a general fund line? How would we?
Well, there's a couple ways to do it. Number one, it's obviously overages in, the insurance premiums would allow us to put money back into the reserve. Or if we take an allocation from the general fund and put it back in the reserve, we can also do that. So, I mean, that's a matter of choice moving forward here, but I think the real, consideration is, we just are running desperately, well behind, okay? And, if you're asking for what percentage we're looking at, as a treasurer, I'm gonna say 27%. But in reality, I understand that's impossible, but I think we're almost at the point where you have to do the middle, the 12% or the 15%, and then it may happen again next year, depending upon what takes place. That's,
BJ, when we get rebates from the pharmaceutical, do those go directly to pay the healthcare costs, or are they allocated?
And I did have that on here with the
They come-
asterisk, just saying it's prior to our rebates.
And do we have any sense of what those rebates will be for the year?
Budgeted.
We're hoping for $1 million.
$1 million.
The first quarter
Yes,
came
I
in
did.
at about $250,000.
Matt, do we have any money left in ARPA that we can allocate to this reserve fund?
I don't think we can use it for that.
you can't use ARPA for reserves. Has to be for one-time expenditures. Yeah.
So I guess it's between 12 and 15%. 15% helps build our reserves back up. We're still running at a deficit.
But if we get the $1 million in prescription, and it's 300 less than the 12.
Right. And again, this is certainly based on the claims being the same. If we are fortunate enough next year to hopefully, you're looking at potentially one claimant not meeting stop loss to make the difference.
If it does go down, we can revisit it next year.
Right. Which is what you do every year anyway.
I know we're talking about a large number of employees across a number of pay grades, but how does this difference per check compare to any raises that they were given in 2023? Is somebody going to say my raise basically pays for the increase in insurance?
I can only assume that certain people will be looking at that way. I can't comment on the percentages of the raises.
I think it would be a disproportionate hit to the people who are lowest paid. People who are higher on the pay scale won't feel this as hard.
As much, right?
Everyone's eyes are gonna bug out at 15%, but the people that make the least in the county are the ones that are gonna be the hardest hit. And some of them that, I don't have the two numbers in front of me, but I imagine it wouldn't work out that way.
But in that case, the difference would be to continue to have a premium plan at a relatively low cost.
Matt, you mentioned ARPA funds are for one-time uses only. Would it be possible to consider a one-time payment to employees as sort of a bonus that would offset some of this, some of the increase if we had to go with a higher increase on the insurance?
I'd have to look at that. I don't know what's eligible, what's not eligible. I do believe that health insurance was not one of the eligible
It
categories.
wouldn't be specifically for health insurance. It could just be a retention bonus. I mean, you know, there's a fairly wide amount of latitude for using ARPA funds to give one-time payments to employees.
Haven't we already done that
You've already done that,
across the
unfortunately.
spectrum?
No, I know, but we have a new circumstance here, so I'm just trying to think outside the box because I'm sure family, that's 32.
Okay. Move forward, let's, everyone's 15%. Art, are you all right with that? I mean, we're not all right with it.
I'm not all right with that, but it seems like the prudent thing to do.
Path forward.
Okay, so we, in the form of a motion, there's only 3 of us, so,
Do we have a quorum?
yeah.
Yeah.
Yeah, I'll make a motion that we adjust the health insurance premiums by 15%.
I'll second it.
Second. Discussion? All in favor? Aye. Opposed? Carried. This gets forwarded into finance. Next finance, so we're doing,
Yeah,
we're
we
doing
have
a
to do a
special
resolution.
finance,
We have to do a resolution.
not a board meeting.
I mean, these are hard choices. But I don't see,
What are you gonna do?
Like I said, if it goes up 6%, you're already 2 million behind. With the 15%, you know? Hope for the best.
Anything else?
I just want to thank you and Lori for a fantastic presentation.
Really great.
And Steve, Betsy, everybody.
I don't know if this makes anybody feel better, but if you compare this to community rates, it's still
Yes.
about 10% less than what you pay as on a community rated plan. So it's still a lower cost than a comparable plan, you know, on the street.
Had we stayed HMO, you mean? Is that what?
Well, even a one that you use nationally. And I did spend some time, Lori and I spent some time looking at the Tompkins County. We need more time to analyze it, but some of the rates are quite a bit higher and they have a huge pool of people. My thinking on that was if we had more people and we could spread out the costs of a similar type of thing, consortium that's been talked about so much. But in fact, they have a lower cost region and their rates are just as high or higher. So this is a national problem. Everybody knows the system's in a crisis.
Do we have any data that shows that people are missing less work because they have better insurance?
That's a great question. There is an idea that, you know, telehealth was supposed to help with that and urgent care help was supposed to get you back out on the street faster. I think that's how it was sold, but Brenda, I don't think that happens.
No, but I'm just thinking that so many vulnerable populations suffer, they go to the wrong place, they go too late because they don't have access. We're providing really good access and, you know, contributing to a very good plan. So I'm just wondering if there's a way to, you know, document that with any kind of data.
If we saw a drop or a lower percentage of missed days compared to other municipalities, I suppose we could do that. I'd have to look at some of the research if you want me to. I can try to dig through it.
I don't know how much trouble.
We are an aging population, by the way. I remember not that long ago, we were about 41 and 42 years old on average. And if I'm not mistaken, when CPHP came down recently, it was more like 49 now, even with the new hires. And so that makes a big difference as far as utilization goes. So of course, that means they're wiser, smarter, making better decisions and spending less money in other places, right?
In terms of aggregate people covered, has that number been steady or has it been going up or going down over the last couple of years?
It's been steady,
Steady?
yes.
Well, after the
Pine Haven.
Pine Haven left, yeah, it went down quite a bit.
Right.
And then it stayed, it's pretty much
Yeah.
the same, There's about 100 people less. That was a big statement.
Okay.
Well, I was just saying, asking PJ, in our town, we realized that the insurance and cost and healthcare insurance exceeded our 2% tax cap. So, that's another way I talk to people about it. We have to exercise the 2% because it contributes to the additional healthcare costs, but it doesn't cover those costs. So just looking for ways for people to understand what our limitations are. We can't print money yet. Thanks, everybody. Good job.
Okay. Motion to adjourn,
So moved.
second, all in favor? Opposed? Thank you.
This is-